So I'll be introducing Dr. Defries. So she earned her MPH in global health at Columbia University. Then we were lucky that she joined UCSF, starting from medical school. And then she also completed her internal medicine residency and addiction medicine fellowship here at UCSF. So she's board certified in both internal medicine and addiction medicine and provides care for patients as a primary care doctor and also addiction medicine at the San Francisco General Hospital. She also directs the UCSF Health and Human Rights Initiative and the Institute of Global Health Sciences and co-leads the National Asylum Medicine Training Initiative. We're definitely lucky to hear about this talk. It's still a topic that I feel like I always need to be refreshed about, but is so needed for a lot of our patients. So we really appreciate you coming and talking to us today.
Thanks so much, Christina. I have to say, I'm totally in awe that anybody is here right now. And this is an incredibly difficult and charged morning and day. And I'm really grateful for those of you who came out this morning and are opening your minds to hearing information about alcohol use disorder. I think we're really connected in this collective taking care of our patients, which we'll continue to do today, and we're so lucky to do. I'm going to talk about alcohol use disorder. I have given this talk before to the hepatology fellows, and I believe in this grand rounds, it's a lot of bread and butter about alcohol use disorder, but as Christina mentioned, it's something so part of our daily practice that we're going to review a lot of basics about alcohol use disorder management, and I will sprinkle in a couple of updates as we go along. I have no conflicts to report, but I will be talking about the off-label use of some medications today. And here's our agenda. Really, we're going to talk a little bit about the burden of alcohol-related harm, screening, and treatment with a focus on the pharmacotherapies for alcohol use disorder. And let's ground ourselves for a moment in the recommended language when we talk about this topic, or really any topic of substance use. And stigma related to addiction and substance use is one of the largest barriers to recovery and to treatment. And a lot of that stigma is propagated in the healthcare system. A lot of our patients present to us really late, don't come see us at all, because they've been harmed in the healthcare system by stigma and by bias against people who use drugs and alcohol. And so we can really do our part to combat this when we use clinically accurate and person-first language to talk about alcohol use. And that's in our own documentation. And when we work with learners, we're always teaching people. And so this is something that we can continue to teach others. So you're going to hear terms like alcohol use disorder instead of alcohol abuse. You're going to hear terms like person with alcohol use disorder instead of alcoholic. You're going to hear terms like alcohol-associated cirrhosis or liver disease instead of alcoholic cirrhosis, medically managed withdrawal instead of detox, and recurrence or return to use instead of relapse. So just quickly to refresh ourselves on kind of the public health and epidemiology background around unhealthy alcohol use. So alcohol use is a harmful substance when we think about it in terms of risk to the individual and risk to the society. And this is particularly just helpful to think about for a moment because it is a substance that's so readily available and legal in our society, but has great harms. And when it has in this study from the UK that looked at the harms of alcohol related to other drugs, it actually ranked most highly. And US mortality data now has been able to show through looking at death records across the United States that excessive alcohol consumption is something that has led to a very, very significant amount of mortality in the United States. So here's a cross-sectional study from many deaths between 2015 and 2019, and note that this is pre-COVID. And it found that 1 in 8 annual US deaths is attributable to excessive alcohol use. And here in California, think it's particularly notable to think about this, where 1 in 4 deaths were among people between 20 and 34 years old, and 1 in 5 among 35 to 49-year-olds. So this is like people in their very productive years of life, and something that is incredibly impactful. And then there's other studies that also look at mortality data, and they show really noteworthy increases in deaths among women, American Indian, Alaska Native individuals, and due to liver failure amongst younger age groups. So I wanted to note that as well. And today we're going to talk about some of the evidence-based individual level treatments, but really I'm starting with this big picture here to say that to prevent these deaths, to really make a dent in it, there's also a need for broader implementation of population level prevention and treatment policies. As you have seen in your practice, in your lives, alcohol consumption and its harms really increased during the COVID-19 pandemic. And studies have certainly demonstrated that now. And you can see here how alcohol-related deaths increased during COVID and kind of plateaued after that, but had not returned yet to pre-COVID levels. And I think we're still waiting to see if at this point they've started to come down. And how are we doing in San Francisco itself? So if you look at alcohol health indicators from our most updated substance use trends data in San Francisco, what I kind of take away from this is how alcohol-related deaths and acute deaths rose, and treatment admissions actually fell with the timing of the pandemic, and that these really had not returned to pre-pandemic levels. So people were having trouble and continue to have trouble accessing treatment. And with increases in alcohol use disorder, or AUD, we also see increases in alcohol-associated liver disease, ALD. It's now the most common indication for liver transplantation in the US. ALD is the leading indication for waitlist registration, and has outpaced other causes, including hepatitis C and metabolic dysfunction associated liver disease as well. And so how does alcohol really work? It's not something that I had really learned prior to thinking more about this in my training in addiction medicine, but unlike other drugs that are very targeted, very specific, alcohol has very widespread effects through the brain, and through different neurotransmitter systems that affect the dopamine-mediated reward pathways. And because it interacts with so many brain neurotransmitter systems, including the opioid system, the GABA system, acetylcholine, serotonin, endocannabinoid systems, and more, there's really a variety of neurochemical targets that have been used for a diversity of medications that have been tried for alcohol use disorder. And so we're going to talk about some of these medications in detail today. And this also helps to think about the medications a little bit, but during intoxication, alcohol has a GABAergic effect, and then when it's used chronically, GABA gets downregulated, and glutamate via NMDA receptors is upregulated. So when people are in withdrawal, when we meet them, their glutamate effect is increased, and they have those excitatory symptoms of withdrawal. And those are the targets of medications for alcohol withdrawal, which you've probably used before and seen used a lot. And so this just helps us to drive home, like, what are actually the neuropharmacological effects of alcohol? And because it has really widespread effects across different types of receptors and systems, we see really widespread physical and psychosocial effects. Today, we're going to focus on the liver effects of alcohol, but really, as you can see, there's so many common primary care issues, cancers, trauma, adverse childhood events, so many different effects that we see across multiple systems, and alcohol is unique in that way. So how do we assess for alcohol use? Well, here in the US, the lifetime exposure to alcohol is really high. Nearly 86% of the US population has used alcohol at least once in their lifetime. But only a portion of those people actually go on to have riskier use, right? Or to have problematic use or heavy use of alcohol. So how do we find out who those folks are? Well, just like any substance use, alcohol use occurs on a spectrum. And so unhealthy alcohol use, you're going to hear me using that term. It is sort of an umbrella term, And it spans from risk use, which is drinking above safer limits, all the way to alcohol use disorder at the top of this pyramid. And that is what is diagnosed when people develop more negative life consequences of their use. And you'll see that the majority of people are either in this abstinence or low risk bucket, but a minority of people have more severe disease. And I think as gastroenterologists, as hepatologists, as people who work in the hospital, we often see more people at the top of this pyramid. And so this can feel inverted at times where we're kind of have a biased view and we see people that have more consequences of their alcohol use and have more severe disease. It's also important to remember that we're also seeing people that have that riskier use, and we should think about how to intervene on them too. So we're going to talk about that today. And so to really be able to intervene, we have to be able to detect unhealthy alcohol use. It's really the elephant in the room, though, often with a patient, and it's often not addressed. And that's despite recommendations for universal screening of adults and pregnant people for many, many years. And despite that, only 1 in 6 adults report having ever been asked about their drinking. So how do you screen for unhealthy alcohol use? And this is a standard screening approach, and I think this is really helpful to think about. It's the most simple one, and it's just one question to really keep in your brain. But the first question is, do you drink alcohol? Do you sometimes drink beer, wine, other alcoholic beverages? And if that's yes, then the question is, how many times in the past year have you had 5 for men or 4 for women or people over 65 or more drinks in a day? And this question has fairly good sensitivity and specificity for detecting unhealthy alcohol use in several different settings, particularly the US primary care setting. And if that is positive, so to follow up a positive screen to that question, a standard approach would use a tool like this, which is a 3-question audit C, to identify who likely has alcohol use disorder. And this has been abbreviated from the audit, which is a validated 10-question tool from the World Health Organization. And this risk stratifies patients for targeted interventions for AUD. And so in this umbrella of unhealthy alcohol use, we have people who are characterized as having at-risk drinking when they're drinking above these limits here, these low-risk drinking limits. And then we have people who have alcohol use disorder, which is diagnosed by the DSM-5 criteria. And, these safer drinking limits, they're a little bit tricky, right? There's no universally accepted safer drinking limit. They're different by country. Canada actually has a very different approach than the United States, but this is currently what we have as our recommendations. And, you can note that for men, it's no more than 4 drinks in a day and no more than 14 drinks in a week. And for women, it's no more than 3, no more than 7 in a week. And people over 65 fall in the same category as women. Now, you may think to yourself, like, I take care of patients with liver disease. Like, there's no recommended amount of alcohol that is safe for consumption. And that's true. These drinking limits need to be individualized to the patient in front of you. Consider there's no safer use limit for pregnant people, similar to ALD. And so you really have to think about the patient in front of you, their goals, their comorbidities, to better individualize their recommended drinking limits. But oftentimes this is a helpful starting place, especially for a patient that doesn't have ALD. And this is actually a figure that I bring up in the room all the time with patients. And to be able to really discuss those limits with patients, there has to be a common understanding of what is a drink. And so safer drinking limits should be contextualized using these standard drink amounts. And just like the limits, there's no universal definition of a standard drink, but in the US, it's defined by these amounts, and each of these contain 14.5 grams of ethanol. Also really helpful to bring up this image with patients so that they can start having a sense of how many drinks they're actually having. It's very hard to know. And oftentimes a drink that is served or something that someone considers one drink is actually more than one drink. So when people are using alcohol, they're using above these limits, and it's leading to ongoing negative life consequences, it then becomes a disorder. which is defined by the DSM-5 criteria. And having 2 or more of these symptoms present in a 12-month period meets the criteria for alcohol use disorder. And the more symptoms present, the greater the severity. So let's move to a case. So you have a 40-year-old patient seen in your clinic. You're seeing this person they were referred to you for abnormal LFTs. And you're talking to them more. And they describe that they have cut back from 6 to 8 beers a day to 4 beers a day. They're having severe cravings whenever they try to quit. They're not confident that they can stop. But their goal is to cut back at this point. Their family members have expressed concerns about their drinking. They have woken up before with hangovers. They've had to miss work. And they have had, they've needed to drink more. They've started drinking more during the pandemic. They've needed to drink more for effect. And they've never experienced withdrawal before. So we're going to look at the DSM-5 criteria real quick. Sorry, I didn't leave enough time for us here before we went to the case. But we have these DSM-5 criteria to think through. And these take a look at the symptoms, and they're framed here as questions. I presented them as questions because I think it's helpful to start thinking about how you might ask about some of these to a patient. But they generally fall in a couple different domains. One is impaired control with alcohol. So have you ended up drinking more longer than you wanted? Have you tried to stop, couldn't stop? Social impairment. So has your drinking made you sick? Has it caused job troubles, school troubles, trouble with your relationships with your family and friends? Has it made you stop doing things that you like to do? So that's social impairment. The other is risky use. So have you gotten into risky situations, driving, swimming, other things while or after drinking that have increased your chances of getting hurt? Or have you continued to drink even though it was making you feel depressed or anxious or adding to a health problem like your known cirrhosis? Have you had blackouts, hangovers, things like that? And then last is the physiological criteria. So that's like the physical dependence that we often think of, withdrawal, and then tolerance. So have you had to drink more to get the same effect? Okay, so those are your DSM-5 criteria. And here's our patient. Here's the story that they've told us in clinic. What do you think is the diagnosis? And we have 28 people. Feel free to come off mute or put something in the chat.
I would think at least C if I take a stab, because it looks like they're having severe cravings, they can't cut, they cut back, they have relationship problems. So it seems like at least 4 points, if not borderline severe.
Mm-hmm. Okay, thank you. So yeah, when we go back to our DSM-5 criteria, based on what this patient said, this person actually had like 6 or 7 criteria that they met. So they have a severe use disorder. And what I want to emphasize is like, oftentimes, the information about these symptoms really comes out in an open-ended manner. It just comes out when you're talking to somebody, what's your relationship with alcohol? Tell me how it's going. Is it okay if I ask you about alcohol? Tell me how it's going. And if you do that in a really open-ended way, people will talk. And you can think about what they're saying, maybe even pull up the DSM-5 criteria and think about how many criteria they've touched on. You don't necessarily have to ask these questions in a checklist fashion. It really can come out in a conversation, and sometimes it takes multiple conversations to clarify a diagnosis. If you feel like you want to implement some sort of screening in a more standardized way, there is something called the symptom checklist, which has all these questions on it, and a patient could fill out like as a survey. Okay, so we've diagnosed a patient with severe alcohol use disorder. Now, how would we treat them? A little more information. So this was a person with depression, now severe AUD that we've diagnosed, hypertension, abnormal LFTs. Let's say for the purposes of this case, they had an ultrasound which showed cirrhosis and no ascites, and this should be abdominal cirrhosis. And you've been able to, in the workup thus far and with their PCP, rule out other causes of liver disease. So you're fairly sure this is alcohol-associated liver disease. Here's some more information about their labs, and think about and take some votes on what medication you would recommend to them for their alcohol use disorder.
People can also write on the chat and I can let Dr. Defries know as well what's on the
Great.
chat.
And there's more than one right answer here.
I would say the one that I'm most familiar with would be like A or D.
Okay, so we have a vote for acamprosate or for naltrexone. Awesome. So let's explore that a little bit more. So just to remember that a patient like this, even if they were seen in clinic, even if they were screened, they would very rarely receive any treatment. So looking at national data, very small rates of treatment for people who've been identified with AUD. And that's like less than 10% of people, 7% of people receive any treatment. That's any type of behavioral treatment or medication treatment for AUD, and even fewer people receive pharmacotherapy, less than 2% of people. There are racial disparities in prescribing. So there's now 2 studies that I often reference that show in the VA that there was a lower prevalence of medication initiation among Black patients. And then in September, there was just a study of Medicaid enrollees that showed that Latina females and males had lower treatment utilization. And then for your patients, for cirrhotic stage ALD, even fewer people are getting pharmacotherapy, 0.4% in a large VA study. So huge treatment gap here. There are low rates of prescribing medications for hospitalized patients as well. So we have a big study now that of Medicare beneficiaries that looks at medication initiation across the US at hospitalization. And you can see here that rates are very low. We're talking about, less than 1%, less than 1.5% of patients in the hospital being discharged with a medication for their AUD, even if they came in with a primary diagnosis related to a complication of alcohol use disorder. And interestingly, this other recent study I wanted to share shows that actually outcomes can be way better when you initiate medications for AUD at hospital discharge. So same thing, looking at those Medicare beneficiaries. This study was able to demonstrate improvements in outcomes related to readmissions, even all-cause mortality, primary care and mental health follow-up, when people were initiated on medications for AUD at hospital discharge. And so for this patient with ALD, we know they would generally face low rates of AUD treatment, but there's also benefit to treatment for them, even if they have ALD. Studies show that MAUD medications for alcohol use disorder are associated with reduced hazard for all-cause mortality as well. So, certainly building the argument to provide medications for AUD. And I just want to say that most people, and the way that I was trained, is most people were offered something or taught to offer something called a brief counseling intervention for patients with unhealthy alcohol use. And that can be effective for somebody who has at-risk drinking, and I'll talk about what that counseling intervention is. But for somebody who has more severe AUD, moderate to severe AUD, a brief counseling intervention alone is not enough. A medication plus a psychosocial intervention should be offered. And that brief counseling intervention is generally about 10 to 15 minutes of raising the subject, thinking about drinking goals, arranging close follow-up. But when we think about offering medications to our patient with severe AUD, we have a lot of different options. I had mentioned at the beginning that there's a lot of different types of medications with very different mechanisms that have been used for AUD. And there are 3 approved, FDA-approved medication options, and then several non-FDA-approved medications that are used. And I've bolded the ones that generally we consider to be more first line. And I just wanted to say that these medicines have very different mechanisms, but they have a lot of common features. So these are generally very safe and well-tolerated medicines. They have few medication interactions, with the exception of disulfiram. They can be safely combined with alcohol if your patient drinks and takes these. They are easier to manage than most medications we prescribe, honestly. And the majority of them can be started or stopped without much titration. And they can also be combined together safely. And you may be wondering, like, well, how effective are these medicines really? And so I think the easiest way to think about their effectiveness is through the number needed to treat. And this is very powerful. When you look at the number needed to treat for acamprosate and naltrexone, two of our FDA-approved kind of first-line options, these are very favorable. 11, 18, 12 is sometimes cited. And if you look at the number needed to treat of other really common medications that we use, like a statin for prevention of an MI or DVT prophylaxis for prevention of a non-fatal PE, the number needed to treat for these medications for alcohol use disorder is far superior. So this just goes to show that these medications should be tried when we can and should be offered. So let's go through them briefly. And happy to delve more into details and questions. Naltrexone is generally our first-line medication, and it's an orally bioavailable mu opioid receptor antagonist. It works by decreasing the reinforcing endogenous effects of alcohol, and it can be given as an oral tablet at 50 milligrams a day. That can be increased sometimes to 100 milligrams per day if someone's having partial effect. And then it can also be given in a monthly intramuscular gluteal or ventrogluteal injection. Naltrexone can be used for two different goals, for if people want to reduce their drinking, and the number needed to treat for that is 12, or if people want to be fully abstinent, to never return to drinking, and the number needed to treat is 20 for that. It can be safe if people drink on it, so that's very helpful. And it's generally very available and it's pretty cheap, and it's great that it has an injectable option for those people who struggle with adherence. It's also been studied in combination with gabapentin, so that's probably the most frequent combination of medications that we see. The major issues that come up are, one, around liver concerns. When naltrexone many years ago had a black box warning for hepatotoxicity based on higher doses of naltrexone that were given for obesity at doses higher than what's used for alcohol use disorder. That has since been removed, and more small studies are showing safety of naltrexone in the setting of liver disease, especially compensated cirrhosis. So increasingly, naltrexone is recognized as safer for people with liver disease than we previously thought. We don't have amazing large studies or trials that look at this, so it can be helpful to kind of hang your hat on something. And often what can be used is markers of the synthetic function of people's liver, and that can, so you can use the child's Pew score. And if they're A or B, naltrexone can be used. At C or D, I would really stop and consider, and really think about making an individualized risk-benefit decision for the patient in front of you. So every now and then there's a patient who's going to say, naltrexone worked incredibly for me. And they may have, concurrent liver disease that might be somewhat decompensated. And you can talk about it and potentially make a determination that the hepatotoxicity of ongoing alcohol far outweighs the potential hepatotoxicity of naltrexone. And you could think about that decision and really individualize it to the patient. You can also look at the AST, ALT. Sometimes 5 times the upper limit of normal is kind of used as a benchmark. The other piece with naltrexone to consider is that it can't be used in people who are using opioids. It's an opioid receptor antagonist. It will precipitate withdrawal or make people really sick if you give it to them if they have opioids in their system. So gotta ask, do you take any opioids? And explain what an opioid is. Methadone, heroin, fentanyl, any pain pills. If they're in the hospital, take a look at their MAR to see if they've gotten recent opioids. The most common side effects of naltrexone are some headache, dizziness, or GI side effects. It's usually in the first week, and it can often be mitigated by giving people half of a pill, 25 milligrams for the first couple of days before they go to the full pill. And I just wanted to, I had, had been mentioning that indeed naltrexone can be used in the setting of liver disease, and even in the hepatology and gastroenterology literature, it is still included as a first-line medication. And so that is certainly something to consider instead of take off the table for all patients with liver disease. Acamprosate is the next most strongly evidence-based medication supported by placebo-controlled clinical trials next to naltrexone. Its mechanism of action is a bit unclear, to be honest, but the idea is that it mitigates symptoms associated with sort of protracted withdrawal when people have stopped drinking after the first couple of weeks. It is most effective for patients who have a goal of complete abstinence. The number needed to treat for that is 12. So it's unique to that goal. And it is safe to use in the setting of liver disease, but it does have to be renally dosed. It has a pretty high pill burden. It's 2 pills 3 times a day. Disulfiram or antabuse is a medication that you probably learned about in medical school. This has, I would say, mixed evidence. It doesn't have as strong evidence as the other 2 medications we've talked about. It obviously is a medication that can only be used for people who want complete abstinence. Otherwise, they can get very sick when they take it. And somebody who, really can understand how to use it. It's been found to be most effective when it's given in supervised administration. So maybe it's a family member or somebody who gives it, or maybe they go to a methadone clinic and that's where it's administered. That's what we do in our methadone clinic here at SFGH. People have to be careful about being exposed to other alcohols in sauces, mouthwash, hand sanitizer, things like that. Interestingly, like I've always taught that this medication really can't be used with concurrent liver disease. But, I have learned that when you look back at the studies, there's actually very little data that points to it being hepatotoxic in itself. And so it's something that could be considered in people who have like child's A cirrhosis, so have a much more mild disease. If it's somebody who has had, previous success with disulfiram, for example, which sometimes patients will tell you. Topiramate is increasingly recognized as a first-line option alongside naltrexone with a pretty promising number needed to treat. The one thing with topiramate is it does have to be titrated up on a schedule and then tapered off if you stop it. And it can have side effects. It can make people have some cognitive impairment or slowing, paresthesias, sedation, appetite suppression, etc. And so it does need to be titrated up slowly, and potentially, you can target a lower target dose of like 100 to 200 milligrams rather than the 300 milligrams a day that's generally used for AUD treatment. Topiramate has a lot of other uses. There's people who have other indications for weight loss. It's been studied in people with co-occurring PTSD or TBI, and it also has been studied for cocaine use disorder. Gabapentin, also used very commonly for alcohol use disorder, often because people are already on it. If I find people who are already on it, I'll often up titrating it to about 600 milligrams TID for AUD dosing. And that can be very helpful. It can also be used as a treatment itself for mild to moderate alcohol withdrawal, and has been found to be particularly effective for people who have a history of withdrawal alongside their AUD. Baclofen has been listed as first line in the AASLD guidelines for a long time, and that's because it's the only medication studied in a trial in people with liver disease. That said, at higher doses, it's something that can potentially have real harms. So I use it less frequently than I used to. There's really been limited data about the safety of these medications in the setting of liver disease and in patients who are really medically complex. And that probably is what leads to such low rates of prescribing, in part among patients with cirrhosis. But as I said, there's more and more studies in this space, including this large retrospective cohort study of over 9,000 patients with AUD that were looked at over 10 years at a single site. And in multivariate analyses, they saw that getting any AUD medicine was associated with a decreased incidence of ALD and a lower incidence of hepatic decompensation in patients with cirrhosis. So for patients with ALD, those associations were strongest for naltrexone, gabapentin, and topiramate. Interestingly, there was a finding that acamprosate, which has that favorable liver profile, was associated with an increased risk of ALD, and that likely has to do with higher risk patients that were chosen for acamprosate treatment. But all in all, these results suggest that there is a benefit of naltrexone, as I mentioned, though many clinicians have avoided that due to limited data on its hepatotoxicity. And there's also an importance of the non-FDA approved medications for patients with ALD. So if we come back to our case here, there's multiple right answers. Naltrexone, topiramate, or gabapentin, as we just saw in those studies, could be recommended to this patient. This patient has a goal of cutting back, and any of those medications could support that goal. You may wonder why acamprosate isn't chosen here. This is a patient with Child's B cirrhosis. And the reason is because acamprosate targets that goal of complete abstinence. And this was a patient who clearly told us their goal was to cut back for now. And here I kind of summarize an approach for medication selection for AUD. And the approach targets people's goals, so understanding if they want to reduce their drinking or target complete abstinence, and then also to target their comorbidities. So we've talked about decompensated liver disease and thinking about acamprosate, gabapentin, or topiramate in those cases. We've talked about adherence challenges. That might be somebody who could benefit from extended release naltrexone, a monthly option. Concurrent opioid use would mean that a patient should not be prescribed naltrexone. Interestingly, concurrent stimulant use, we'll think about something like extended release naltrexone or topiramate. Both of those have been studied for the treatment of stimulant use, cocaine or methamphetamine use. So sometimes we can target two use disorders with those medicines. In the setting of renal disease, you do need to dose reduce acamprosate and gabapentin, as well as topiramate. And if somebody has concurrent anxiety or insomnia or a history of withdrawal, gabapentin can be particularly helpful. And really, these kinds of medications are supported in the hepatology literature for use in both patients who have cirrhosis as well are pre-transplant or patients who are post-liver transplant as well. And so those can certainly be provided by hepatologists and gastroenterologists. And we're going to talk increasingly about collaborative care models that we can use to take care of those patients together. I wanted to quickly do a sort of fun case. This case is a little bit different than our last case about severe alcohol use disorder. So in this case, we have a 23-year-old male who is admitted to the hospital. You, as the GI doctor, get consulted for choledocholithiasis and you're following this patient. But in the hospital, they end up getting screened for unhealthy alcohol use, as we actually do in a standardized fashion at SFGH. Actually, all the bedside nurses are screening patients with the audit C. So this person screens positive to this single question first. How many times in the last year have you had 4 or more drinks? He screens positive. Talk more with him about that. It comes out that he's been drinking a lot. He drinks 10 or more drinks at night, but only on Saturdays or Sundays when he goes out to clubs. So it's really like binge drinking. He feels hungover the next day. He's made some decisions he regrets when he drinks like that, but otherwise he hasn't experienced any ongoing like major consequences or from his drinking or issues with controlling his use. So his audit C is greater than 5, and you end up like looking at the DSM-5 criteria and thinking about this story, and he meets like 2 to 3 criteria, like maybe for the hangovers, maybe for having some negative consequences. So he's somebody who has mild alcohol use disorder with those 2 to 3 criteria, or maybe at-risk drinking, like he's binging and he's drinking more than recommended limits. So for this, and he's drinking when he goes out. So it's really like around these times that he's going to nightclubs. So look at these options, and what would you like to offer him? Because you as his gastroenterologist, you're also thinking about like his liver health here, and you're learning this history, and you're like, I think I need, I need to offer offer him some support around this drinking, because I know it will impact his liver eventually.
Triveni, I think naltrexone. If looking at his LFTs, I would consider it.
Okay. Let's explore. Let's go through all of these because they're kind of fun. So, safer drinking tips. Well, yes, this is somebody drinking above safer limits, someone with at-risk drinking. And there is, there is some like counseling you can offer folks in this boat. And you can actually talk to people about how they are drinking, not just like how many drinks are you having in a day, but how are you drinking? And I really, really like this resource called Rethinking Drinking from the NIAAA. And you can Google it. You can also like order a free book from them online in English or Spanish. But if you Google, there's a lot of really, really helpful tools there that help people to keep track of drinking, help people to see how many drinks like they're actually having. You can use their cocktail calculator, which is very interesting, and put in like the craft cocktail that you had at some fancy place and see how many drinks were actually in it. It has tools on there that can coach people through how to avoid triggers, how to handle urges, how to actually say no to drinks if they want. And so I think it's really helpful to talk to people about these small changes that they can make. And, if one of these approaches doesn't work, like they can try something else on there. And this is something you can use to talk to both your patients who have at-risk drinking, so like this patient, or those that have more severe alcohol use disorder. These are all helpful strategies. And likewise, like there's all of these drinking tips that reduce the harms of drinking. So things like eating food before you drink, not mixing alcohol with other drugs, like pre-planning your ride, maybe alternating your drinks with water, putting ice in them, things like that, that you can talk to patients about. And if you start asking them about how they're drinking, they will probably teach you about some safer drinking tips that they're already using. Okay, what about dry January? Should you recommend that to him? Maybe your friend tried it or you tried it. And, it's kind of interesting. I just wanted to bring up that there's an increasing movement of like the sober curious here, of people really exploring their relationship with alcohol. And there is a study now that actually shows when people engage in dry January, they, at 6-month follow-up, they actually had fewer days per week that they were drinking. They were still drinking less 6 months later, and they had a sense of achievement. They had saved money, they had lost weight, they were sleeping better. So there were some sustained effects of those kinds of explorations of sobriety. So, there may be patients that are asking you about this increasingly. Okay, what about C? There must be an app for this. There really are a lot of apps out there now. I don't like endorse any of the particular ones I've listed here, but there are many free apps and then apps that you can pay for. And they do help people to track drinks. They have things in there that are like for cravings, like how to manage cravings, really all sorts of tools. And there was a study of university students in Switzerland that found that using a smartphone app helped them to decrease drinking over a whole year. So something else to explore with your patients. Okay, and so Gloria had mentioned, well, what about naltrexone for this patient? This is a patient with at-risk drinking or mild AUD. Earlier in this talk, I told you that medications like naltrexone should be offered to people with moderate to severe AUD, but what if it's just like this person who's like binging at the clubs, but not necessarily having moderate to severe alcohol use disorder? Well, there's a small study from San Francisco, actually, that came out last year that looked at using PRN naltrexone for binge drinking specifically. And so people were given 50 milligrams PO, like a standard dose of naltrexone that they could take when they anticipated that they were going to binge drink. So generally this was taken like before they would go out to a club or go out at night or whatever. And it was associated with reduced binge drinking, and those outcomes were sustained over 6 months post-treatment. And there really were no major side effects. The naltrexone PRN was safe and tolerable. So, this is one really small study, but just putting it out there that occasionally this kind of conversation will come up with patients, and it's not wrong if they want to try naltrexone PRN. Not everybody's going to be able to anticipate their cravings or anticipate their drinking, so it's not necessarily the right choice for everybody. And then those people who have more severe disease should be given naltrexone daily, not PRN. Okay, option E, you've probably heard, like psychedelics increasingly used for addiction treatment. And indeed, there is like an RCT of using psilocybin versus placebo for people with AUD. And, you know, just in summary, like this, it was safe. There were really no adverse effects of using psilocybin in a study that looked at this question. But what I will mention is that this was administered with a lot of structured psychotherapy. So something to consider, and definitely something we might be hearing more about. And then lastly, I mentioned a managed alcohol program. Maybe that's something you haven't heard about. Should this person who's like binge drinking go to something called a managed alcohol program? Well, this is an intervention that is used, it's a residential setting that is used for people who have very severe alcohol use disorder and complications of their alcohol use disorder. Generally, this is used for folks who are unhoused. So it's a residential setting where they can continue to drink and actually be given alcohol in a supervised setting in monitored quantities. And this has been shown in the US and Canada to be associated with people really both stabilizing their housing and some chronic medical conditions. So I wanted to present this sort of as an option that's at the frontiers of harm reduction when we think about alcohol. But for this patient who's binge drinking, this would not necessarily be the appropriate intervention. This is for folks with really, really severe use disorders. Yes, yes. And Gloria mentioned that the San Francisco map did close, and I really don't know much about what's going on with the program, to be honest. Yeah. So for this second case we looked at of this younger patient who is in the hospital with cholelithiasis that you were consulted on, and you ended up talking about their alcohol use and found out that they had some at-risk drinking or mild alcohol use disorder, and you want to intervene so that they don't progress to have more liver complications, so that they don't progress to have more severe disease. We have a lot of different options. We can talk about safer drinking tips. We can talk about their relationship with alcohol. There's things like apps, maybe even naltrexone PRN that can be tried. And you know, in summary, like a lot of people ask, well, what are the right outcomes? Like, what are the optimal outcomes when we're offering these kinds of strategies or when we're offering medications for alcohol use disorder? You know, and generally we think about total abstinence being the optimal outcome. But I just want to offer to you that there's increasing evidence that decreased drinking, decreased quantities of drinking are really good clinical outcomes too. And that reductions in the amount that people are drinking are associated with benefits to their liver, in addition to decreased, you know, blood pressure and other measures, better quality of life, and even sustained medication effects for the medicines we've talked about today. So, you know, even welcoming reductions as a potential good outcome, that might align better with some of your patients' goals, and it might make you feel like we're doing a better job at treating people and encourage us to provide these medications more often. It's notable that, you know, even the definition of remission from alcohol use disorder, we talked about the DSM-5 criteria. There's actually in the DSM-5 definitions for remission and recovery. Remission is when somebody initially has up to 3 months of not meeting those DSM-5 criteria, early as 3 months to a year, and sustained as a year or more. And these are based on not meeting those DSM-5 criteria that we reviewed together, except for the one of craving. So if people have ongoing cravings, that's okay. That's part of having the disease. But they're not meeting the other issues of impaired control and negative consequences in their life. And note that abstinence is not part of this definition, right? It's all about not meeting the DSM-5 criteria. Okay. So increasingly, you know, we have great models. I'm just going to go here of collaborative care between people like me, addiction medicine clinicians, and GI or hepatology providers. There is data to show that, you know, both locally here as well as nationally, there's not a lot of prescribing of medications for alcohol use disorder happening among GI and hepatology providers. And you know, there's a lot of reasons for that, but large ones are like a lack of familiarity with prescribing, worries about side effects. And so hopefully today in talking about this, we've been able to allay some of those fears and help to build some confidence and comfort. And then I wanted to also offer some of the information about ways here at UCSF that we can collaborate on taking care of patients with ALD and AUD. One of those is the UCSF HALT Clinic, which is a multidisciplinary clinic launched in 2023. We have a team that involves hepatologists. It's Dr. Sherman and Dr. Klepper who are on this, I think on the Zoom still. An addiction counselor, Davina Martinez. I see patients for addiction medicine consultation. And we see folks with alcohol-associated cirrhosis, and I'm seeing people really at all parts of the spectrum, both, you know, ALD, pre-transplant, post-transplant. And so that is a resource. Other resources are the Bridge Clinic at San Francisco General Hospital, which is an addiction clinic that's pretty low barrier. It's open every day of the week in the afternoon, and patients can drop in. And there's an e-referral in Epic at San Francisco General for the Bridge Clinic as well. We have at UCSF as well an addiction medicine clinic that's available on e-referral, and you can ask them questions, particularly about medications for AUD, and they'll give you recs and sometimes see patients. If you're practicing really anywhere, even after you potentially leave UCSF, you can call the substance use warm line. I'm one of the consultants. There's several of us. And you can call about any substance use related management during business hours. And we just talk clinician to clinician about recommendations. And then lastly, in the hospital, both at SFGH and I believe at UCSF now, we have inpatient consult services. So that is another resource to be able to consult. And in summary, you know, we talked about screening all adults for unhealthy alcohol use. We talked about using some brief counseling for people with at-risk drinking, and then prescribing medications for people with more severe alcohol use disorder, and selecting those medications based on their goals, based on their comorbidities, and really including this as an integral part of their ALD care. So I will stop there. And I think we have 3 minutes for questions.